There is a move now towards going to 4-drug quadruplet combinations upfront, and the goal is really to get to an MRD negative state and to try and maintain that MRD negative state and hopefully transform what we're seeing as chronic disease into a fraction of patients who are actually cured from the disease as well. At the time of relapse now, typically those curves have shifted somewhat so that our first relapse for myeloma happens anywhere around 3.5 to 4 years from the time of diagnosis. There's more and more data now looking at triplet combinations. We're using a whole bunch of triplet combinations, and a lot of what we do at the time of relapse is dictated by what the patient has already had and the nature of relapse, the risk associated with the relapse. But typically, even in the relapse setting, we tend to use a triplet combination. Now, in the United States, I think the majority of our patients are progressing after having been on a lenalidomide maintenance kind of an approach. So we are mostly picking a POM-based approach, whether it's POM with daratumumab, POM with carfilzomib, or POM with some other agent remains to be seen. And then depending on what they've had at first relapse, second relapse, and so on and so forth.